stepwise. Let's come back. It sort of goes back to what I was asking you. We can all dive in on this. Ed, you too. How do you recognize who gets them? In other words, you said stepwise. You'll try somebody who's tried A, tried B, tried C, but then you said, I see somebody really bad, I'll jump right to D. And he's going to jump right down your throat.
Right. I mean, again, we're not going to jump straight to that systemic agent.
I don't know about that.
So, well, look.
Well, it's not a dental discussion, but.
You know, I take a generally very stepwise approach. So even when I have a sense that they're going to require a systemic agent, I do recognize that there's at least a subset, even of those most severe, that can respond well to topical agents first. So it's certainly worth giving that effort before committing them to long-term systemic management. Right now, there certainly are providers out there who are using pulse dosing of systemic steroids or pulse prednisone as a quick fix, you know, when someone comes in with a flare before a wedding or things like that. And so I think that even in those scenarios, no one's going to jump to using dupilumab for a year when you're trying to get that quick fix. So I think it's recognizing that when patients have really chronic disease, where automatically you're going to run into real safety issues with the current systemic agents out there, so that chronicity is a big issue. And that's, again, going to be a smaller subset because so many of the patients have just sort of seasonal flares and things like that, or those who really have failed other options.
Okay, well, let me make it more difficult, unless you wanted to add something here. Go right ahead.
Well, I think, though, as we get drugs that are approved by the FDA to treat mild to moderate, as crisaborole comes out, and we've got that as a mild to moderate, in my mind, maybe it's just too simplistic to say topical corticosteroids or TCIs as a first step above all of the bathing and the hygiene purposes. And then for a patient who doesn't respond to topical steroids, then there's a topical non-steroidal new agent that's indicated. And then dupilumab comes on as the moderate to severe alternative to that. That is the first, or should be the first approved in moderate to severe.
Wasn't that what I was just asking you about 5 minutes ago?
I agree. I think the topical PDE4 inhibitor is going to, that's probably even a less clear place in therapy.
Well, it's non-steroidal. In my mind, it works when steroids don't.
Well, so
do you step through that
well,
before you
I
get
think
to
that's
dupilumab?
the interesting part. I think for dupilumab, I think almost everyone would agree that it's certainly reasonable to step through with topical steroid first. I do agree. I think this is a little more unclear with the, or less clear, I should say, with the crisaborole because, you know, in a perfect world, we would never have to deal with topical steroids. If we had some cheap non-steroidal options out there, we would all just like to throw topical steroids away. So, you know, this is not going to necessarily be cheap to start with, but, you know, in theory, if it had the efficacy comparable to a mid-potency topical steroid, we'd love to see it used in everyone. And obviously, that's a scary statement, but, you know, what do we do with these? Do we step through these or not?
Right. Is it a replacement or is it another step? I think that's what we're saying, and that's, I don't know. Yeah.
So let me ask Ed. I'm going to keep this away from you for a minute, but let me ask Ed, do you think that payers are going to recognize that it isn't just the size of the rash or body surface area affected, but all these other comorbidities? And I come back to sleep, itching, quality of life, just the general annoyance of this thing. Are they going to recognize those as markers for approval of these newer drugs?
You know, I think they can, you know, but I think that this is something that the dermatologists and other specialists who are treating these patients are going to have to help us with. And there's a couple of different ways to do it. You know, in some disease states, we have a list of things and you check off 2 of them and you get the drug. And in others, we look for a more global type of assessment, not necessarily the things we're calling global assessment, the specific ones, but, you know, looking for more of, you know, how bad off is this particular patient. And so what we're really looking for here is who are the patients should go right to this drug. And then perhaps the patients don't have all of those symptoms, or maybe they didn't score so high on that, but they're resistant to other therapies, so they have nowhere else to go. So I think that the payers would take that into account, but we're going to need to have some way of measuring that and some way of tracking it back to the clinical trial, even if it's just to say, well, in the clinical trial, 30 or 40 or whatever it was percentage of patients reported they slept better at night. That's fine, and then you can add sleeping better at night as one of the ways of adjusting this medication for the patient and figuring out if you're going to use it.
But I want to go into more. Go ahead.
I think the other point too to bring out in this area is you're talking about, because we're really talking about what is the criteria for utilization. And for mild to moderate, for crisaborole, that's 2 years old and up, that drug was studied. But in dupilumab, these are adults and with moderate to severe. And I think that part of the population, that 1 to 3% of the population?
I mean, there's some, it's probably, eczema in the overarching sense a little more common in adults than we may have realized beforehand, but the moderate to severe atopic dermatitis population is going to be way less than 1%.
Okay.
You're talking about a much, much smaller segment of the population. So, what gets interesting is fast forward 5 years from now, if dupilumab gets approved for kids, that's a whole different conversation, but we're nowhere near there at this point.
And just to be clear, it seems to me that what we're talking about with these two new agents, with crisaborole and dupilumab, is disease modification, not symptom modification, right? That's huge. I mean, again, we come back to, I can manage your symptoms, I'm going to give you this, I'm going to give you that. But these two drugs, one topical, one injectable, change the disease, at least theoretically, right?
Right.
That's got to be an enormous change.
Absolutely. And, not only are we talking about the potential of, really minimizing flares, minimizing between flare itching symptoms and everything else, keeping the skin clear, there's the potential of really taking it down a notch long term as you really intervene on that mechanism. And we need to see more data about that, but that's a very interesting and exciting principle that comes out of this.